Hello, welcome again to Miami Community Health. I am Dr. Anthony Gonzalez with Live Longer with Dr. Anthony Gonzalez. Welcome to another new year of life. Now, this year, I want to do more of what we've been doing in the past few years. I want to educate you, the population, about health, about how to live longer. And we're going to start the year off in January with a very important topic. If you want to live longer, you need to have blood in your body. Blood is very, very important. We're going to talk about the importance of blood. January is National Blood Donation Month. Why? Why is it January? Well, because blood donation is very important, but blood donation falls off in December. It falls off in December because people are busy, because of the holidays, because of the winter illnesses where people can't donate blood, and therefore there is a drive to donate blood in January. So to talk about blood, talk about transfusions, talk about blood banking and the importance of blood, I brought you a specialist, a pathologist, a doctor who has a specialty in transfusion medicine. So I want you to welcome today Dr. Eduardo Benzi with us.
All right. Well, Dr. Gonzalez, very nice to be here. Very nice to meet you. And thank you for having me.
Pleasure. So Eduardo, explain to us who you are and what you do. What is this pathology, transfusion medicine type of thing?
Well, a pathologist is a physician, is a person that went to medical school, and pathology is a field where you study disease. So our specialty is to diagnose and study and understand the disease processes in the human body. A transfusion physician it's a board-certified specialty of pathology, whereby you deal with everything that is relating to blood and the blood supply, blood in the sense of blood that is administered to patients, that is taken from donors and given to patients, and dealing again with the safety, the integrity, and the purity of the blood supply. And blood supply, we mean red cells, we mean platelets, we mean plasma, and all of the other human-derived products that you can receive as a patient or that you can administer as a physician to a patient at a hospital.
All right, so let's talk a little bit about blood transfusions. You're talking about blood and obviously giving transfusions. Are there different types of blood transfusions?
Yes, so when we think of blood, and I like when I describe blood, I like to think of it as soup. Blood is like soup, it's vegetable soup. You've got vegetables, larger vegetables, smaller vegetables, you've got broth. The larger vegetables, you can think of your white cells. The smaller vegetables are your red blood cells, which you think of, oh, I'm getting blood, I'm thinking I'm getting red blood cells. And you've got very, very tiny little pieces like little beans, those are your platelets, and then you've got the broth, and that's your plasma. So patients will receive, we usually break this down. When we receive the blood, we can break it down into the components. We can have white cells, we can have red cells, we can have platelets, and we can have plasma. So patients can receive any one of these products, in addition to some other ones that, I don't want to get too specific here, but all of these products can be administered to patients in different situations depending on what they need. Typically, when patients think of a blood transfusion, they think of a red bag of blood. Those are red cells. And, those would be administered in situations where the patient needs red cells. Typically anemia is your classical indication for receiving a transfusion of red cells.
So yeah, it's important to clarify that when you're getting a blood transfusion, you're not getting that whole blood from somebody. You're not, and that's the term, whole blood, so people understand. You're not getting all of those components. You're just getting the red cells.
Correct. Yeah.
And why don't we give the whole blood?
Well, there are indications for whole blood, but typically when you give what we call a component therapy, we give blood components because it's more directed. A lot of the time a patient will not need the plasma and the platelets and the white cell. No, you can just, if a patient has low red blood cells, i.e. what we call anemia, low or little blood, little red cells, you can just give the red cells, and it's more targeted. There are situations, for example, in patients that have very severe trauma, that, for example, gunshot wounds, very severe car accidents where they lose a lot of blood very quickly, where you can administer whole blood, which is, these are bags that come directly from patients that they are processed, but less processed than components, and they can be given in these situations. But generally, when you think of blood transfusions, you're giving component therapy: platelets, plasma, red blood cells.
All right, we know there's different types of blood types: A, B, O. So talk to us. Positive. I know I'm A positive. Mm-hmm. So is it important that I'm A or B or O? Is that important or is it indifferent? And what about the positives and the negatives?
Okay, so when you think of blood groups, everyone's heard of, O negative blood is very valuable, it's very rare, etc. But when we think
Is it rare? Is it O negative rare or
relatively?
Is it? Okay.
Relatively rare, and there are advantages and disadvantages to O negative blood, but to having O negative blood and to giving O negative blood. The reason that O negative blood is so important and that your ABO types are so important is that O negative red cells, they're considered your universal donors. So if a donor has O negative blood and they decide to donate that O negative blood, practically any patient can receive that unit of O negative cells regardless of their blood type. We think of O negative blood as the universal donor. And it takes a little bit to explain, but when you think of ABO, these are proteins that you find on the red cells. And patients who are, you have your 4 classical blood types, AB, A, B, and O. A and B are proteins that you find on the red cells. A patient that is A has the A protein. A patient that is B has the B protein, and a patient that is AB has both. Okay. A patient that is O does not have that
either.
Exactly. So patients who are B have antibodies against A. Patients who are A have antibodies against B. Patients who are O have antibodies against both. So in patients who have O cells can give those O cells, and they will not have a reaction in anyone. In AB, A or B patients or O patients. Yeah. So it's an ideal product to give to anyone. It's a universal product.
And that's why important you have to get the similar type of blood. So theoretically, if O is not available, if you're A, you have to get A blood, or else, if you get the B, you're going to have the antibodies, and that will, you'll obviously attack that blood.
Exactly. Is if you have A blood, you can get A blood or O blood.
So let's talk about safety of transfusions, because I also want to talk about what happens if you get what we call like a mismatch, or you get the wrong type of blood. So are transfusions safe? Am I going to get hepatitis, HIV from blood?
Those are all very good questions. When we think of blood safety, this is something that we have worked very hard over the past 50 years to make sure that transfusions are safe. Blood transfusions are the most common procedure performed in the hospital. Wow. And blood as a product is very, very strictly regulated by the federal government, by the FDA, and by accrediting bodies within the blood transfusion community, the AABB primarily. So when you think of blood transfusion safety, the first thing that we need to make sure is that the patient is getting the appropriate blood, i.e. the blood that is indicated in a timely fashion, and that component they're receiving is safe and high purity. So then there are many ways that we ensure that. First, we ensure that the safety of blood transfusion, that you're not getting the wrong type of blood. So a lot of the times we'll have to have there's a standard procedure. We have to draw 2 different tubes of blood from the patient at 2 separate times, and that blood is typed twice to make sure that is the patient that is the correct blood type for the correct patient. Then we have to ensure that the product is correct. We do multiple procedures. We call it cross-match, where we mix the patient blood with the donor blood to make sure that everything is safe.
So actually, you're doing almost like a transfusion outside the body to see if there's going to be a reaction before you give it to the patient.
Correct. Yeah. So there are many, many procedures to make sure that the blood is it's not going to be 100% safe, but it's going to significantly minimize the risk of a severe or life-threatening reaction. We do not want that. There are other reactions which are common, especially with red cell transfusions. You can get a fever from that. From a red cell transfusion, it's actually the most common complication of red cell transfusions is a fever. And then we stop the transfusion, and if it needs to be repeated, we'll get another bag. Sometimes you get allergic transfusion reactions. Most of these allergic transfusion reactions are mild, sometimes itching, sometimes hives. Again, we stop the transfusion. We give the patients medication if necessary, and we can either resume the transfusion or get a different bag, depending on the severity of the reaction.
So those are the risks with regard to transfusion reaction.
Correct.
What about the risk of HIV or hepatitis? Any other things that you can get from the transfusion?
Also, another very good question. The risk, we call these infections. So HIV, hepatitis C, hepatitis B, these are all infectious risks of transfusion. We have done a lot of work over the past 30, 40 years to reduce that, and we've done a very, very good job. So the first thing that we do is, and for anyone that has donated blood before, when you sit down to donate blood, you get a questionnaire. It's called the Donor History Questionnaire. And in the Donor History Questionnaire, the blood bank will go, the Blood Donation Center will go over a series of questions, many of which are to assess for risk factors. So at the very first step, before collecting blood, donors that have high-risk behaviors or that are at risk for having these infections are screened out. So already the donors whose blood goes into the donor pool are already very low risk. They're already screened. Following that, the blood is tested by the blood center. It's a series of tests. These are molecular tests, these are DNA tests, these are protein tests to make sure that the blood is negative before it goes into the blood supply for a series, and not just HIV, hepatitis B, and hepatitis C. We also test for babesia, we test for trypanosoma. These are all other infections that the blood has to be negative for all of those before it enters the blood supply. And if at any point this blood tests positive, it is discarded. It is thrown away. It does not enter the blood supply. So the theoretical risk of contracting something like hepatitis C or HIV is very, very small. We're talking about 1 in 1.5 million units transfused.
And that's improved, right? Because I had heard stories. I've been around long enough to have heard stories, whether it's true that a patient says, oh, I got HIV or I got hepatitis from a blood transfusion. We've improved on that maybe in the last 20, 30 years?
We've improved on that significantly over the past 20 or 30 years, yeah.
Wow,
that's
and
again,
incredible.
With multiple different, very, very sensitive and very specific tests that we do in the blood bank. And if we find out, for example, at any point that a donor tests positive for any of these diseases, but most specifically hepatitis C or HIV, we do a look back. We find any kind of products that these patients may have donated in the past, and we recall them. These products do not enter the blood supply, and if it has been given to a patient, in the tragic event, the very unfortunate event that it has been given to a patient, that patient will get follow-up as well. We make sure that patient gets followed up.
That's good. That's good to hear. Now, you talked a little bit about, why somebody would need blood. You talked about, anemia or somebody bleeding, God forbid, a motor vehicle accident, a transfusion. But what about the other components of blood? We talked about the red cell component, but there are other components. You mentioned white cells, you mentioned platelets. Who may need those type of transfusions?
So platelets are any patients that have what is called thrombocytopenia, which means thrombo means clot, cyto means cell, penia means little, so not enough clotting cells, not enough platelets. And these patients generally it's most usually in the setting of leukemia or a blood cancer that the patients will have low platelets. These patients will get transfused with platelets. And then plasma, usually patients that have some kind of clotting disorder will get plasma as well. And again, plasma is just the broth, and it has it has a lot of clotting proteins, and those are the primary indications for platelets and plasma.
All right, so let's focus a little bit now on the donor people, because we're trying to encourage donation. We're trying to bring awareness to donation. Who can donate blood?
In theory, anyone that is healthy can donate blood, or at least you can definitely go to the blood center. And you can go through the screening questionnaire, and if you pass the screening questionnaire, you can donate blood. And depending on your blood type and depending on what you're willing to do, you can donate whole blood, which is the classical. They're going to put a needle in your arm, you squeeze, you get a bag of blood. They take the bag of blood and they usually will give you something small in return, a slice of pizza, a T-shirt. Anyone can do that, and who is healthy.
And how often can you do that?
Well, that depends on what kind of product you're donating, but usually 6 weeks in between donations of whole blood. So every 6 weeks you can donate blood.
And when you say donate whole blood, I mean, we're going to take the whole blood from you. That's the only way to take it. What happens if you donate only a component? How does that physically work? I don't even, So
they hook you, they put a needle in your arm, they hook you up to a machine, and the machine will separate the platelets or from the red cells and return to you your red cells. They'll take just the platelets. It can be done.
Wow, that's awesome. Okay.
Yeah.
And is it safe?
The most common complication of blood donations is you get a bruise in your arm.
Okay.
Every now and again, you'll get there's a small risk that some patients, they get what's called a vasovagal reaction, where they faint. They see the blood, their blood pressure drops, they faint. It's a common reaction, but it's not the most common reaction. The most common complication, or the most likely thing that you'll get after a blood transfusion, is a bruise on your arm.
Now, you mentioned obviously those that can, pretty much anybody can donate. You go to the blood bank, you fill out the questionnaire. But, in your mind, and I'm sure this list is not going to be exhaustive, but who should not be going to donate blood? Who should not, even get in their car or even approach this for their benefit, obviously, so they don't hurt themselves, or God forbid, hurt somebody else?
Right. So any patient that is on a medication that has a diagnosis of HIV or hepatitis C or hepatitis B should not donate. Any patient that is sick So
let me clarify that. HIV, now we've come a long way with HIV. Now there's HIV that's like non-detectable. Today, people live with HIV long. They're going to die of heart disease just like everybody else. Those non-detectable patients, HIV non-detectable, should not give blood.
They cannot donate, no.
Okay.
Any patient for HIV to be undetectable, they have to be on HIV medications. And any patient who is on HIV medications cannot donate blood.
Okay. So we heard about HIV, if you've had a history of hepatitis, any history of hepatitis?
So if you have, again, it gets a little more complicated, but if you've had a history of hepatitis B and it is treated and is fully cured, you can donate blood. Hepatitis C and HIV, that's a different story. That's more complicated. Patient, and again, these are the minimum safety requirements. They can also vary by blood bank. Blood banks can impose, or blood donor centers can impose more strict requirements. So, for example, there are blood banks that will not accept any kind of patients with a remote history of any kind of cancer. Even if it's completely treated, they will not accept a donation from those patients. And it varies by donor center. And you can always call the donor center ahead of time and, ask them these questions.
Can I get cancer from a blood transfusion?
You cannot get cancer from a blood transfusion.
No, you mentioned cancer. I have to.
Again, and this is generally for on patient safety grounds.
Okay. All right. So then we hear about all this issue with the mother who's pregnant and the issue with blood type. Talk to us a little bit about what this issue is in very simplistic terms, and the issue with the mother and the baby and the blood types.
Okay. So we have to remember that baby is a combination of dad and mom. Always, and again, baby may receive from dad blood proteins or blood red cell proteins, which mom does not have, and which mom can recognize as foreign and therefore make antibodies to. So
therefore attack the baby.
And therefore attack the baby. So there are ways to mitigate that. The most common thing you'll hear is, mom and baby are incompatible, so mom had to go in and get an injection to prevent her from being, from generating antibodies to baby. There are lots of ways that we can mitigate that. We also screen for it with mothers. We screen the mother's blood for antibodies during the pregnancy.
And that's something that's treated by the gynecologist, by the obstetrician that does that?
Yes, the obstetrician does take care of that.
And obviously a pregnant mom, can they donate blood?
A pregnant woman cannot donate blood.
Okay, so that
until 6 weeks after the pregnancy is over. After 6 weeks, she can donate blood.
Okay. All right. So the issue of this having the antibodies and everything else is not going to be an issue because they will not be donating blood.
Exactly, yeah.
All right. And then let's talk about preparing blood for yourself. Orthopedics used to do a lot of this, I remember, and then blood for your family member. I'm going to donate. My mom is going to have open heart surgery, and I want to donate some blood for my mom. Talk to me about self-donation and what is it? Autologous.
Yeah, self-donation or autologous and directed donation.
Okay, so talk to me about that.
So I'll start with autologous donation. In theory, most people can donate blood to themselves. Again, that blood, what will happen is you'll need a physician order. It'll need to be done ahead of time. You go to the donor center, or to the hospital, depending on where the blood is going to be collected. With the doctor's order, you have to have a hemoglobin of a certain amount. And there are requirements for that. There are minimum requirements. If you're very sick, you cannot donate blood to yourself. Then you'll go ahead of time. You'll have a bag of blood collected. That bag will be separated from the blood supply, labeled, and will be available to you when your surgery happens. This is something that we do for generally these days Jehovah's Witnesses patients who do not receive blood from other people. But it is a safe way to donate blood if you don't want to receive blood from what we call a donor. A direct donation is not something that we necessarily encourage, but it's something that can be done. If, say, you have usually directed donations we do for patients that have very rare blood types and whose family will match their blood type closer than we could with a random donor. So, if you have very rare blood type and you say you have children or you have brothers that have similar blood types to you, then we will encourage a directed donation.
All right, so somebody donates blood, whether they donate it for themselves for their own surgery or they're donating for their family member. How long does that blood last?
Well, that is a good question. That depends on how the blood is processed. It can last anywhere between 21 and 35 days.
So it's very quick.
Yeah.
It's very quick.
Yeah, and then again, that has to do with the life of blood once it is collected and once it's separated. As blood is stored in a bag, it begins to deteriorate. The cells begin to die, they begin to leak out, potassium, a bunch of other things that you don't want to give a patient unless it's absolutely necessary. You don't want to give a patient an expired unit of blood.
And is it important to get blood that's only 5 days old versus blood that's 25 days old? Is that something a patient should be asking in the hospital?
So for most adult patients, that will not make a difference.
Okay.
We like to save very young units, under 3 or 5 days old, for babies, for very young babies, for neonates, for intrauterine transfusions, for babies that need it inside the uterus, because again, as the cells in the bag begin to die, the level of potassium, which is potassium is a salt that is dissolved within the blood cells. It begins to leak out, and that can have some very negative effects in the babies because they're so sensitive to it.
Wow.
So we save the young units for the very young patients, very, very sensitive patients. But in an adult patient, that generally doesn't make a difference.
Okay. And then, so what happens with that expired blood?
We throw it away.
Literally throw it away?
We throw it away.
Wow.
We dispose of it, appropriately. There's an appropriate
not in the regular trash can. It
doesn't go in the regular trash, no, but we get rid of it.
Okay. And is there a lot of wasted blood? Or, I thought overall we have a shortage of blood available, or is it temperamental? Is it time based? Or
so again, we try not to waste blood because it's an important resource. It's not something that you want to throw away willy-nilly. There is blood wastage, unfortunately. Sometimes not every unit in the hospital gets used, and we have to throw it away. Sometimes because the blood supplier will have the unit in consignment, which means that the unit is at the hospital, but technically it belongs to the blood supplier. The blood supplier can redistribute units that are about to expire. That can be done as well. There are many ways that we can avoid wastage.
All right. And then lastly, a topic that's gotten a lot of press recently, very important topic, COVID. Right? And, there's been this controversy of the vaccine, the implications of vaccine. The vaccine caused problems. So people who have been vaccinated and are donating blood, is that being tested? Is that being labeled? Is it safe? Not safe? It doesn't make a difference. It doesn't get into the blood, the vaccine. Talk to us a little bit about that.
So that's there was actually a very interesting, an interesting article published in the Journal of Transfusion this month about this. So the COVID vaccine, it's very difficult for you to track among donors who has been vaccinated and who has not.
Because people are lying.
Well, some people lie, which we don't recommend. If you're donating blood, please do not lie. This is very important, and this is important for your family.
If you've been vaccinated, you can't donate?
No, you can donate. Okay. You can donate.
Why do you ask the question? Why do they ask?
We do not.
Oh, they don't ask the question.
We do not. And even if we could, patients donors have a lot of difficulty recalling when they got the vaccine, which manufacturer vaccine they used,
But they
how many
are
doses.
They are asking it, I guess you're saying.
We can ask. Some,
Okay.
again, most places do not.
Okay.
The overwhelming majority do not, again, because it is so difficult to track. And patients who are hesitant to receive blood because of the concern about the donor being COVID vaccinated. Again, as a transfusion physician, I think most transfusion physicians would agree with me. We are happy to talk to these patients to discuss any concerns that they have. You can talk to your physician, have them call us. We are happy to discuss. And again, and this is just a general rule. If a patient has concerns about the blood product they're receiving, if a physician has concerns about the blood product the blood bank is issuing their patient, the transfusion physician is there to clarify, to discuss whatever it is that the physician or the patient needs. We are here for that, to explain, to improve, to make sure that the patient is getting the best care and the best product in the most timely way possible, for their need and their condition.
So do I know when I'm getting a unit of blood whether it's been a COVID vaccinated blood or I don't know that?
No.
Is that labeled?
No, we
Is
do
it
not
tested?
track that. We do not track that.
No.
No.
So whether to ask if it's safe or not, we have no idea.
Well, it is, again, we have been using this blood for the past 4 years of blood that patients that have been COVID vaccinated, patients which have not been COVID vaccinated, and there has not been a significant difference in the safety of the blood supply.
Okay, that's good to know. And I think one of the important things you said is if there's a doubt, if you have a concern, at Baptist Hospital, we have somebody like you who's a transfusion medicine expert, a blood bank expert. If you or your family member is in need of a blood transfusion, you're concerned about the integrity of that blood, the safety of that blood, somebody like you who's a physician, an MD, who has the training, the specialty training, can come down to the bedside and say, hey, Mrs. Smith, Mrs. Jones, this is what's going on, and I can, vouch for it. I can answer your questions and put them at ease. I think that's very important to know.
Yes, absolutely. We are, we don't see patients often because we are pathologists. We're kind of on the back. We're kind of backstage, but we are there for patients whenever those patients need us. We are physicians as well. We are clinicians, and we are there when called upon. That's what we're there for. We're there to ensure that everyone receives the best care possible and the best unit possible, the best product possible for their need.
Perfect. Well, thank you. Thank you for doing that.
Thank you for having me.
Thank you for being here. Thank you for educating our population about that. And as I said at the very beginning, we're just trying to help you live longer. Live longer with Dr. Anthony Gonzalez on Miami Community Health. And part of living longer is obviously helping others, and helping others by donating blood. January is Blood Donation Month. So if you are able to donate blood, like Dr. Benzi says, you don't have a history of HIV or hepatitis C, go ahead and give some blood and help others as well. So, Dr. Benzi, thank you for being with us. And thank you all for listening to us and being with us today on Miami Community Health. Live longer with Dr. Anthony Gonzalez. Take care of yourself and your family.